Hi, class. This is Dr. Weaver. I wanted to go ahead and do this recording for musculoskeletal system. I'm going to start with slide 23 on this presentation, and so that should allow us to take our time when we begin to speak about this in class. And to be honest, if we get a chance to speak about it in class, unfortunately, I believe it's next week. Our next class meeting will have the exam two, and so I don't believe that we would have a whole lot of time to touch on the musculoskeletal system a whole lot because the exam obviously takes up quite a bit of that time. And then, of course, in the seventh week, I guess that might be the only time that we'll be able to discuss musculoskeletal. So hopefully, so we'll do the best we can with the very little time that we have. And of course, this is the reason why I have to do these voiceovers, because it's just really difficult with all these exams to actually get some teaching actually done. Anyway, so I am sharing my desktop, and we're starting off with developmental competence in infants and children. All right. So, as far as infants and children are concerned, by the age of 3 months gestation, that growing fetus has formed a kind of a scale model of the skeleton that is made up of mostly, well, actually, all of cartilage. It's not actually bone yet. All right. Um, so during the succeeding months in utero, this cartilage begins to ossify into, of course, true bone, which is much harder, of course, than cartilage. And then, of course, it will start to grow at that point. Now, this bone growth, it will continue until after birth, rapidly during infancy, and then, of course, there's the steady increase in growth during childhood as well as until adolescence, when of course, boys and girls undergo this rapid growth spurt. Right. Now, long bones grow in two dimensions, your book talks about. They increase as far as width and also diameter. And this is due to deposition or depositing of new bony tissue around the shaft part of the bone. All right. Now, lengthening occurs at what we call the epiphysis, or we call it also the growth plates. All right. Now, this longitudinal growth, it continues until these plates, the epiphysis plates, close. And of course, the last closure actually occurs at around the age of 20 years old. All right. Now, although skeleton contributes to linear growth, and of course, we're talking about getting a taller. As far as weight is concerned, most of the weight actually comes from muscle as well as fat, not so much as from bone. Bone, of course, it is mostly responsible for more height, if you will. All right. Now, the muscles respond to increased secretion of hormones such as adrenal androgens. And in boys, further stimulation is due to testosterone. Now, muscles vary in size and also strength in different people, of course, and this is because of that genetic programming, also nutrition as well as exercise. And all through life, muscles increase with use, but of course, they will begin to atrophy if there is little use, of course. Actually, let me increase the size of that. All right. Now, as far as the pregnant woman, there is increased levels of circulating hormones that cause increased mobility of the joints. This is also due to, the hormones that we speak of, I should say, is due to estrogen, also hormones called relaxin, and also corticosteroids. These hormones are generally produced in the cortex, yes, of the adrenal gland, right? There is increased mobility in the sacroiliac. These are different bone structures. Sacrococcygeal, symphysis, pubis joints in the pelvis, which contributes to those noticeable changes that you see in the posture of a pregnant woman. Now, most characteristic change is what we call progressive lordosis, leading to increased back strain. This puts a lot of strain on the woman's back, and of course, what you will see is this compensatory postural change, anterior flexion of the neck. So the neck basically flexes forward, and slumping of the shoulder girdle is also seen in the pregnant woman. All right. And now, so the upper back changes may put pressure on the ulna and also the median nerves during the third trimester. And of course, because of that, you will begin to, or the woman will begin to experience some neurological changes. For example, numbness and tingling, if you will, because again, those nerves are being compressed by that growing fetus. Continuing with developmental competence, the aging adult. Um, we talk about, or your book talks about bone remodeling. It is a cyclic type of process referred to as resorption and also deposition. Right. So, so the standard pattern for bone resorption to equal, or rather, it does equal bone replacement. So when we talk about resorption, you're talking about, for the most part, taking calcium away from the bone. But then you also have this deposition, or this calcium being placed back in the bone. So there's this balance, if you will, all right, because you can't have total resorption, because that means that you have all this calcium that is being taken out of the bones, which will make them not very strong, hard and whatnot, and stable. And of course, this can lead to fractures and what have you. Right. Now, so basically, when there is bone resorption or loss of that bone matrix, when it occurs very fast, then the net effect is a gradual loss of bone density, or it can lead to what we know as osteoporosis, which you normally see in older women. This tends to happen at a much greater rate in women, by the way. Now, osteoporosis is a disease involving the loss of mineralized bone mass, in particular calcium. And of course, it causes the bones to become more porous. All right. And of course, again, as I said, these patients are more susceptible to fractures very easily. Now, whenever as far as health promotion, we have to encourage these patients to do resistance and weight bearing type of exercises, because this does tend to increase the density of bone, in particular the hip and the lumbar spine. All right. Now, this type of exercise has to be done pretty regularly, with, of course, high intensity. This is not something that you do every now and then. And this would maintain it would maintain the strength and the stability of our bones. Of course, once you go back on this level of activity, then all that you have done is going to be lost. And so we have to inform them as far as their health promotion and maintenance to continue. Now, postural changes are evident with aging. Long bones do not shorten. They don't become short with age. There's also a decrease in height of about 3 to 5 centimeters that occurs it occurs rather with shortening of the vertebral column. It is also caused by a loss of water content, and also thinning of the intervertebral disc, and by also a decrease in the height of individuals' vertebrae from the condition osteoporosis. So that loss of height comes from a variety of factors that you should be familiar with. Right. Now, loss of subcutaneous fat leaves those bony prominences more marked, such as uh, the tips of the vertebrae, the ribs, the iliac crest, and what have you. And there's also the body hollows are deeper as far as the cheeks of the face, as well as the axillary. And so there's this absolute loss in muscle mass that will occur. Now, some muscles decrease in size, and some will atrophy as well as a result of aging. And due to this, there's going to be quite a bit of weakness in these patients. And this is why you do see weakness in patients as they get older. It's because of the muscles, they're getting much smaller. Now, lifestyle also affects musculoskeletal changes. That sedentary lifestyle, it does hasten those musculoskeletal changes related to age. But as I said, physical activity will increase the skeletal mass and helps prevent or delay osteoporosis. And so this is why our elderly needs to be very active. No time to just sit in the rocking chair, right? All right, and here, as far as the culture and genetics, I'm going to have you all take a look at this particular section. All right, just talks about this bone mineral density, this BMD, and of course, as we know, older people, especially women, they have a low BMD. Um, because there's less, or the bones are less dense. All right. Um, And of course, when we talk about a density, um, we essentially talking about they're much more stronger. They have more calcium. All right, more calcium. They're more stronger. They're more stable, and what have you, as opposed to a less density. Then, of course, they don't have as much calcium, phosphorus, even, and of course, these patients are more susceptible to fractures and what have you. All right. And just a side note, you do find that in Afro-Caribbean women, the BMD tends to be much higher. Um, and that could be actually due more so to that higher weight bearing activity. Um, and of course, more sun exposure in those Caribbean countries, right? Because remember, with vitamin D, we are able to utilize more calcium in the body. And without it, then we are not able to. Um, All right, and then we begin to talk about some of the subjective data here with a focus on joints, knee joints, muscles, bones, and also there's a functional assessment that we need to think about so we can determine the things that our patients can perform on their own. And also, we'll talk about some patient centered care as well. Now, most of this, of course, can be found in this information related to the different subjective data just mentioned will be found in a grid that is entitled Examiners, the questions that they ask, as well as the rationale behind them. All right. All right. So let me move this thing out of the way. All right. So, for example, and of course, I'll be honest with you, there's a lot of information related to musculoskeletal conditions, and it'll be impossible for me to go through each and everything. So, I will tell you again and again to rely on your readings. I touch some things here and there, try to give you some of the major concepts and what have you. But there's a lot. There's quite a bit. And so, in order for this video not to be 3, 4, 5 hours long, we have to kind of just touch on again some of the more significant concepts. All right. So for example, when we're talking about joints, some of the questions that will be asked or that you will ask the patient is, for example, is there any problems that you're having with your joints? Is there any pain? And so joint pain and loss of function are the most common musculoskeletal concerns that makes a patient seek medical care. All right. A very important question to ask. As far as location is concerned, this is very important. We want to know which joints on one side or both. Reason that is important is because when you think about osteoarthritis versus rheumatoid arthritis, there's a distinction between the two. So, for example, with rheumatoid arthritis, um, it involves symmetric joints, so it would be mostly both sides. All right, and other musculoskeletal illnesses involve isolated or unilateral joints, such as osteomyelitis, um, not osteomyelitis, osteoarthritis. It is more unilateral versus symmetrical. So this is why those questions will be important. Also, it's important when you think about timing. All right. So, for example, you ask the patient, what time of day does the pain occur? How long does it last? How often does it last? Or how often does it occur? And so that's important because here we go again with the distinctions between rheumatoid and osteoarthritis. With rheumatoid arthritis, they typically start off in the morning with pain upon rising, all right? And it does tend to get better during the day, especially with movement. With osteoarthritis, it's more worse later in the day. All right. And so again, this is why it is really important to understand those differences. We also talk about is the pain aggravated by movement, rest, position, or weather? Is it relieved by rest, medication, application of heat, or ice? And this is because movement increases most joint pain, especially in your osteoarthritis, but not so much as rheumatoid arthritis, which I had mentioned, and which movement actually decreases the pain. So just think about that. Again, as we test you on this information, you have to be able to know those differences. All right. You may want to make like a grid. I think I made a grid for another student. Yeah, something like this. This is something I shared with another student. So you may want to put like osteoarthritis, osteoarthritis here, and then you may want to put rheumatoid arthritis here. And so, for example, you might say um, pain at end of uh, pain at end of, oh my goodness, my typing, end of day. Um, and over here for osteo, pain upon rising in the morning, right? And so something like that, I think, is what you guys should think about doing. All right, so that's just an example of that. Let's see. All right. As far as knee joint, there's some questions that you can ask. For example, how did you injure your knee? Um, did you injure the knee on the inside? Was it the outside? Was there twisting? Or is it one of those pivoting type of injuries? Is it an overuse injury such as jumping or kneeling? All right. And of course, this is important because inside injury, knee injury, can strain or rupture the medial ligament, and outside injury can strain or rupture the lateral ligament. So, and of course, then there's an abrupt twisting, which can injure the anterior cruciate ligament and whatnot, something that you would see in especially football players. Those are the type of injuries they sustain. All right. And then just go ahead and read through what the book talks about as far as muscles. So, for example, if it's in uh, does the patient have any problems rather in the muscles such as pain or cramping, and of course which muscles? And there's a term we call myalgia, and just basically a pain. Um, Pain or rather cramping or aching in the muscles, myalgia. All right. There's also if there's pain in the calf muscles, is the pain with walking? Does it go away with rest? And of course, this would go back to what you learned as far as that arterial and venous disease, right? In particular, arterial disease. it can suggest intermittent claudication because as the patient walks, the oxygen requirements is more and they're not getting that oxygen, so then they'll begin to experience pain. The flip side of that is if they rest, then there's less requirement for that oxygenated blood, and therefore the pain will usually subside. It's just based on the needs of the body due to activity. And then, of course, look at bones, what your book speaks about as far as the different questions and the rationale for the questions regarding bones, and also the functional assessment. We want to do your joints as far as muscles, bone. Do you have joint problems that create any limitations on your usual ADLs or activities of daily living, right? And of course, which one? We want to know which one. We want to ask about each category. If the person answers yes or asks specifically about each activity in the category. So what we mean by that is we want to talk about bathing, getting in and out of the tub, turning off faucets. We want to know about toileting, dressing, grooming, eating, mobility, also communicating, and what have you. All these questions are important because we're trying to determine if there's any self-care deficits, and which is one of some of the biggest issues with musculoskeletal issues is that we typically find self-care deficits. In these patients. That's why it's so important for us to learn this type of material. All right. And then we also talk about the patient-centered care. This is any occupational hazards that could affect the muscles and the joints. Does your work involve heavy lifting? We know what that can do to your lower back, right? Or any repetitive motion or chronic stress to joints. Any efforts to alleviate these, which is why companies should provide some kind of ergonomic model, if you will, to ensure that their employees, are not becoming injured because of these repetitive type of um, the repetitive work that they're performing. For example, a lot of typing, can result in carpal tunnel syndrome. And so, in the case that I just mentioned, the occupational hazards with the lifting or repetitive activities such as typing and whatnot, you're looking these patients are at high risk for back pain and also carpal tunnel syndrome and whatnot. Also, another question would be, tell me about your exercise program. Describe the type of exercise and the frequency. Do you do any kind of warm-ups? And so a strict program of regular high dose exercise increases bone strength and also reduces fracture risk. And so this is, again, all a part of that health promotion and maintenance that we have to consider as far as our patients are concerned. We also want to talk about things like how about your supplemental medications, calcium, vitamin D, how many dietary products eaten per day, how many over-the-counter medications are taken. And so dietary calcium, of course, is better absorbed than supplements. All right, so eating foods high in calcium is better than, of course, the supplements. Now, serum levels of vitamin D can be checked, and of course, supplements might be recommended because if you're just not getting enough in your diet, then there has to be another way that we must obtain it. All right, and so these are just some of the questions here that I want you to read in your book about. And I went over some of these, but I want you guys to make sure you go through each category. All right. As far as joints are concerned, we want to know about the pain, location, is it unilateral versus bilateral? The quality, severity speaks to characteristics of the pain, onset, aggravating, precipitating factors, what makes it worse, what happens, is there anything you do before that results in a pain, a joint pain, and so forth and so on. How does it impact your ADLs? So just make sure you go through each one of these items. And then there's questions about the muscles, various questions. This just provides the different questions that we should be concerned about, but your book will also provide information about the rationale as well. Take a look at information about bones, of course. Yeah, so take a look at this information. And then, of course, there's this functional assessment. This is something I talked about already, the bathing, toileting, dressing. It's what we call activities of daily living. And this is a functional assessment that's really important for us to hone in on, the specific task to determine if our patients are at risk of potential injuries because they're not able to carry out some of these tasks. All right, so take a look at that. Also take a look at the patient-centered care. I kind of touched on some of that as well, right? Those occupational hazards at work especially, right? And so just take a look at the specifics regarding this information, all right? And then there's additional history type of questions related to infants, children, as well as adolescents. All right. So your book, of course, talks about as far as infants. For example, you may ask questions like, were you told about any trauma to the infant during labor and delivery? Did the baby's head come first? Was it a breech presentation, right? Was there a need for forceps, which we know forceps can cause hair trauma or trauma, period? Did the baby need resuscitation? Maybe the APGAR score was pretty low and the baby wasn't quite breathing, right? So anyway, so traumatic delivery increases risk for fractures, the humerus, the clavicle, and what have you. There can also be periods of anoxia or without oxygen, which may result in hypotonia of muscles, so very weak muscles, if you will. All right. You also want to talk about developmental milestones, and you have to know what these babies should be doing at different points in time, because if there is a deficit, if for example, if most babies are performing XYZ at a certain age, then we need to know that if this baby that we're examining are there. Are they very far behind, which is when we really become more concerned. So basically, were the baby's motor milestones achieved at about the same time as siblings or age mates, those who are the same age as the baby. All right. And then just read the rest: history of broken bones or trauma, presence of bone or spinal deformities. I don't believe I did that. Let's see. Hold just a moment. I did something that I shouldn't have did. This thing is so sensitive, actually. All right. And then, of course, we get into adolescence, history of sports, history or sports activities. We know that injuries can certainly result from sports. So you ask questions like, are you involved in any sports at school or after school? how frequently, in terms of times per week. The more frequent, the greater the risk of injuries. How does your sport fit in with other school demands and other activities? So what we're basically doing is assessing safety of sport for the child, and also note if the child's height and weight are adequate for a particular sport. I mean, some scrawny-looking child, you would be concerned about them playing football because it's such a brutal sport. Then again, that one may be the superstar, right? Um, uh, do you use any special equipment? Does any training program exist for your sport? So use of safety equipment, of course, in the presence of adult supervision can decrease the risk for sports injury. At least that's what they say. I have a different take on that one. And of course, questions like what do you do if you get hurt? Because students, they may not report injury or pain for fearing of limited participation, of course, in the sport. And so we want to make sure they understand that you have to report these things, because if you don't, then you may find yourself, you know, sustaining something that may be permanent, right? So they have to understand that sometimes we get hurt and you just need to step away, heal, so that your outcome would be better. And then there's the aging adult type of um, questions. Use of functional assessment history questions to elicit any loss of function, self-care deficits, or safety risk would be important. Um, because as we know, the safety risk occurs as the patient ages, or of course, if there's any kind of musculoskeletal illnesses such as rheumatoid arthritis or osteoarthritis and what have you. So we have to complete that functional assessment. We want to know about weakness, any change in weakness over the past months or years. Remember, the muscles, as you get older, they atrophy, they get smaller, they get weaker. We want to know if there's any falls or stumbling over the past months or years. Um, we want to encourage exercise to the best of the person's ability and safety. And of course, a history of falls increases the risk of future falling. So we have to make sure we deal with the present, if you will. We also want to know if the patient is utilizing any mobility devices, canes or walkers and whatnot, what we refer to as mobility aids, something to aid them in their ambulation and what have you. There's also a recommendation for DEXA scanning for females ages 65 and older. Essentially, the U.S. government, they recommend screening women 65 and older because we're screening for osteoporosis. Um, um, and we do this with a low dose X-ray called a DEXA. And we want to know if they have this image. Well, do you know your results? And do you have access to the test? Um, Now, the screening interval for this is 2 years, which is suggested to measure any changes in the bone density. Um, Now, recent evidence does show that if a baseline bone mineral density is normal, um, or the osteopenia is mild, rescreening intervals of 15 years may suffice. So you can extend the time of screening out longer. And intervals of 5 years for women with moderate osteopenia. So depending on whether your condition is mild, moderate, or severe, the more severe, the more frequent the screening, the more stable you are, you can stretch it out a little further. So just keep that in mind as you do your health promotion um, with your patients. right? Now we're going to get into our objective data. So the purpose of musculoskeletal examinations are to assess function of the activities of daily living, and also to screen for any abnormalities. Um, you already will have a considerable data regarding ADLs through taking a history from your patient. And we must note any additional ADL data as the person goes through the motions necessary for the examination. And so we'll be able to look at the patient's gait, their posture, how the person sits in a chair, how they rise from the chair, how they take off their jacket, and manipulate small objects such as a pen, and also raise this from the supine position. All this information can let us know what is about our patient's functional status and what have you. All right. Now, we talk about age-specific screening measures such as the Ortolani's assigned for infants or scoliosis screening for adolescents. And these are just tests to let us know if, for example, if an infant has a dislocation of the hip, and of course scoliosis, we're talking about the spine of our adolescents. As far as this examination is concerned, we do take an orderly approach. It's more of a head to toe, more of a proximal to a distal approach, and also from the midline and then outward. This is how we will assess our patient, of course. Now, the first thing we do is we inspect, then we palpate, and then we take the patient through a series of range of motion movements to see if there's any, of course, limitations. All right. Now, in your book, there's a grid that speaks to the normal range of findings as well as abnormal findings. And so I want you guys to make sure you look at that information. Again, there's lots to go through, so um, um, I don't want to extend this video too much longer than I should. Um, Anyway, so here we're looking at, well, we're noting the size, the contour of every joint. And again, we're just looking right now. We're inspecting the skin and tissues over the joints. We're looking at color, swelling, any masses. We're looking for deformity. Um, Now, the presence of swelling is significant and signals some kind of a joint irritation that should be explored further. There's also the use of the contralateral side for comparison. We just don't look at one side, we look at both extremities, for example, both elbows, both wrists, and both hands, and so forth. Now, swelling may be excessive joint fluid, or what we call an effusion. There can also be thickening of the synovial lining. There's inflammation of the surrounding tissue, such as the bursa or the tendon, or some kind of bony enlargement. So it can tell us a variety of things that we need to take note of. Right. And then, of course, with palpation, we want to palpate each joint, including the skin for temperature. We typically use the back of our hand to assess for temperature. We want to look at its bony muscles, the bony articulations, and area of the joint capsule. If we notice any heat, tenderness, or swelling, or any masses, that's something that we need to further explore. Right. Now, also know that if the patient does have warmth and tenderness, it does signal that there's some kind of inflammatory issue that is occurring. And then, of course, well, I went ahead. And again, we then take a look at our range of motion. We ask for active or voluntary range of motion while modeling the movement yourself as appropriate. Um, and so, so basically, when we talk about active range of motion, the patient is actually doing it themselves versus passive range of motion. You are actually doing it for the patient. All right. And you may have to do the passive range of motion exercise for the patient because they may have some limitations themselves, and so you may have to utilize again passive range of motion exercises to help with the movement. Essentially, a limited range of motion is probably the most sensitive sign of some kind of joint disease. Now, the amount of limitation may alert you to of the cause of the disease. um, I did want to show you, all right, I thought I think there's a chart for you to look at. All right, I'll show you that when I get to it, but there's a chart that actually shows the range of motion, the degrees of that limb or extremity, or different body parts, if you will, because even the neck, there's a certain range of motion and certain degrees, of course, that tells us if there are limitations, if you will. All right. Um, well, I keep passing. Oh boy, I keep doing the same thing over and over again. I keep touching things I shouldn't touch. Give me just a moment. Why do I do that? What's going on too? Just a moment. My computer can be very sensitive. All right. All right. So talk about range of motion. All right. Yeah, this is what I was talking to you guys about. Ask for active voluntary range of motion while stabilizing the body area proximal to that being moved. And of course, if you notice any limitations, then you want to gently do passive range of motion exercise, motion rather, a movement in order to see how significant the range of motion is. Right. And then there is muscle strength testing. We test the strength of the prime mover muscle groups for each joint, and we repeat motions for active range of motion exercises or movements, if you will. We ask the patient to flex for example, the extremity, and hold as you apply opposing force. And of course, this will let us know, if there's weakness, if the patient has good strength. We want to the muscle strength should be done equally or bilaterally. Um, and we want to see if the patient can fully resist and whatnot. That gives us knowledge about the strength of that muscle or those muscle groups. There is a standard grading scale, reports results 0 to 5. Um, Now, a 5, let me just give you the extreme. So a 5 would be a full range of motion against gravity, a full resistance. Basically, they're at 100%. This would be normal. And then, of course, there's a 0. 0 means no contraction, zero, just essentially 0, right? Even, let's say a 1 is like slight contraction, and the percentage would be like a 10, or there's like trace amount of strength for that person. So ideally, for a normal person, we want to see a grade of a 5. All right, but of course, as we know, as you get older, you may find most elderly patients, especially if they don't do much in the way of exercise, you may find them at maybe a 2, a full range of motion with gravity eliminated, so that you know they're at roughly about 25% or poor, if you will. But it may be fair, full range of motion with gravity. So it will certainly be different as opposed to their younger counterparts. All right, then there's the temporal mandibular joint. Go ahead and take a look at the different steps and how to perform this assessment. And actually, your textbook actually gives a nice demonstration of that. I can get to it. Yeah, so this is what that will look like. You're checking the TMJ here. And of course, we want to inspect and palpate this area. If there's audible or palpable snapping, or if you feel clicks, um, this can be considered normal in a healthy person. All right. We also want to palpate contracted temporalis and also the masseter muscles as a person clenches the teeth. And so you have to instruct them to clench their teeth. We also look at the right and the left side for size and firmness, also strength. So that there's that comparison. We asked the person to move the jaw forward laterally against resistance that we're applying. We're actually applying the resistance, and also to open the mouth against your resistance. Of course, this particular test, we're actually assessing cranial nerve 5, or the trigeminal nerve. So this is something that we look at in the neurological or the cranial assessment. Now, if a person does have a crepitus and also pain, this does signify a TMJ dysfunction um, that can that can be experienced through movement as well as chewing. All right. Now, if there is swelling, swelling looks like a round bulge over the joint itself, and although it must be moderate or marked to be visible, if it's moderate or in order for it to be seen, rather, right? Because you're inspecting at this point, it has to be marked or moderate or marked to be visible. So keep that in mind as well. All right. So your book does tell you about, tells you how to actually carry this out. Check it out where it says decreased range of motion occurs with TMJ inflammation and also arthritis. All right. So they're opening the mouth maximally and partially open the mouth, protrude the lower jaw and move it side to side. And so these are just things that we will instruct the patient to do. Lateral motion may be lost earlier and more significantly than the vertical motion, and so forth. And so this is what we will do for our patient as far as the assessment is concerned. All right. And then now we look at the cervical spine. There's so many different components to the musculoskeletal assessment. It's probably the longest one. Maybe it was better that we left this one last. Anyway, so as far as the spine, the cervical spine is concerned, we're inspecting the alignment of the head and the neck. Of course, the spine should be straight and the head erect. We're also palpating the spinous processes, those bony structures over the cervical spine. We're looking at the sternomastoid and the trapezius, as well as the paravertebral muscles. They should feel firm, but they should not have any muscle or spasm or tenderness. You'll note that if whenever you go and you complain, you go to the physician's office and you complain about, maybe some back pain, if you will, they're palpating over the bony prominences. But what they're checking for is one of the things they check for is tenderness, which can signify some inflammatory issue. We also want to, some of these tests, will require using opposing forces to check for strength. The person normally can maintain flexion against full resistance. And of course, this test will we're looking at cranial nerve 11, the spinal nerve, right? And we're observing for any kind of limitations to motion as well as reported pain. And I believe your book, so you all will know how to perform this particular one. This is what I wanted to show you all. Spine. These are all the degrees here, right? So if you want someone, as far as the neck is concerned, you want extension, the head goes back, as you can see there. And if you want the neck to flex, this is the 0 position here. You should at least get about 55 degrees here or 45 degrees as you flex. Over here, as far as a lateral movement, 40 degrees to the right and also to the left, right? This is lateral. And of course, this is rotation, turning to the left to the right. And I can tell you, as you get older, you lose quite a bit of the lateral movement, bending, as well as the rotation. And I'll say this also, and you'll see this with other extremities as well as we go through this presentation. And when I used to work in short-term disability as a nurse, sometimes patients would get injured. Let's say they injured their back, maybe an extremity, if you will. This just like you see these degrees here. There's certain degrees we want to see with someone with a back injury, with an extremity type of injury, and it's how we determine if they have adequate degrees of movement, because that'll let us know if they're ready to go back to work. And what I mean by that, say if you're in a job that requires you to have a good rotation of your neck, and you're only at 30 degrees, right? Then we would essentially say that, well, there's limitations here, and this person cannot do their job, and it may be a hazard for them if they cannot perform this degree of lateral movement. That's just an example. You see, it says here's limited range of motion occurs with arthritis, so it can be arthritis. It can be an injury too. Pain with movement occurs with arthritis or muscle overuse, something you're just doing over and over again, repetition. And then a person cannot hold the flexion. That can also be considered an issue as well. I thought, so that's, so yeah, your book also talks about how you would instruct the person to perform these different range of motion activities, like to touch the chin to the chest. Is what you'll tell the person. you want to see a flexion of 45 degrees. Lift the chin towards the ceiling. So we're talking about hyperextension. You want to see 55 degrees and so forth and so on. So this just basically tells us how to carry that out. And again, you're looking at cranial nerve 11. All right. And then, of course, there's the shoulder, and we go back. There's the shoulder. And so we are inspecting and also comparing both shoulders from the posterior as well as anterior point of view. And do not attempt if you suspect a neck trauma. All right, because you don't want to cause more damage and what have you. So we have to realize, especially when we are assessing the cervical and the shoulders, if the patient has a suspected neck injury, we want to hold off until we get imaging to let us know, to inform us that the patient is stable, and because you don't want to paralyze someone, obviously. If a person reports shoulder pain, ask him or her to point to the spot with the hand of the unaffected side. The shoulder may be from local causes or maybe referred pain, which could be potentially serious. So remember, we talked about the shoulder blade in your cholecystitis patients. So someone can have cholecystitis, and it can be a referred pain to, let's say, the shoulder blade, for example. And so we can't just think that because a person is complaining of shoulder pain, but that it's localized to that region, like in the form of an injury, perhaps. But it can be other conditions, so we have to keep that in mind. Pain from a local cause is reproducible during the examination by palpation and also motion, and so um, we can continue to elicit the same pain response through palpation and motion. So that'll let us know that it's likely more of a local injury as opposed to some referred type of pain. Now, while standing in front of the person, palpate both the shoulders. We're looking at the looking for muscular spasms, any atrophy, which could also lead to muscle weakness, swelling, heat, and also tenderness. And so, just take a look at your textbook as it provides you with how you would instruct the patient to perform these different movements. All right. Yeah, so this is pretty consistent throughout your textbook. All right. And so with this, again, we're looking for swelling, hard muscles with muscle spasms. We're also looking for tenderness as well as pain with these patients. Those are the main issues, what we would call a positive exam. Positive in the sense that something is present, that is. All right. And of course, your book will show you what the range of motion, the range of motion as well as the degrees, which is here. Range of motion, test range of motion by asking the person to perform 4 motions. Cup one hand over the shoulder during range of motion to note any crepitation. And normally, of course, none is present. But look at the different degrees, right? You got 180 here, and then that's at 0. And then when you bring it, those both arms to the back, that's more hyperextension. This is more of a flexion, of course, at this point. But then once you're in the back, then it's more of a hyperextension, and it should be up to about 50 degrees. This assesses for internal rotation, right? And look at that motion there. It should be 90 degrees if you can actually perform that. And this is your abduction as well as abduction. Arms up here, of course, would be abduction, right? And which should be about 180 degrees. And then, of course, you have your 50% should be adduction. Well, abduction is here, 180, and adduction would be 50 degrees here. So, and then, of course, down here, it just tells you how to um, ask your patient to go through these different motions. With arms at the sides and elbows extended, move both arms forward and up and wide vertical arcs, and then move them back. So I know this is a lot. And so what we'll basically do is, again, with the focus sheet, you will be told exactly what you need to really be looking at. This part is just really good to listen to read through, just to, again, get that general overview of this particular topic. But I know, again, it being a lot of information, I'll narrow the focus as much as I can. All right, so the same thing applies. Take a look at the section that speaks to assessing the elbow. All right, and of course you'll be able to look at the range of testing for range of motion and how we assess for strength as well. So make sure you take a look at that information. This is, of course, the elbow here. This is how we assess, the elbow. But as far as the range of motion is concerned, this is how we would do that. When the arm is in this motion, a flexion, we're talking about 160 degrees. And of course, when you extend it, you're back at 0. All right. And of course, after a fall or trauma, full extension of the elbow can usually rule out a fracture. So if they can extend the elbow, then we know that there's no broken bones. And this is, of course, what we expect to see. The flexion should be at least 150 to 160 degrees. Extension would be at 0. Some healthy people lack the 5 to 10 degrees of full extension, and others have 5 to 10 degrees of hyperextension. So, and again, this information is really good to know, because if you got a patient who's out of work, workers' comp, and they're constantly being evaluated for return to work, and so this is what they actually look at to determine if the patient, is ready to go back to work. All right, and so that's the elbow. And then, of course, the same applies to the wrist. So make sure you guys take a look at that. One of the things I wanted to I wanted to show you all real quickly is drop down to the last bullet point that deals with carpal tunnel syndrome. There's a couple of tests that we actually perform to determine if someone does have carpal tunnel, and it's called the Phelan test and also the Tenosine test. And let me show you guys what that actually looks like. That's how we test for strength, of course, here. This is where we're pulling, we're doing the resistance here, and this patient is trying to pull their arm towards themselves or himself. And as far as, let's see, who that is. Anyway, let's see, testing. Let's see, where is it? All right, here we go here. This is the Phelan test, and look at how we'll ask the person to demonstrate this movement here. We can, we physically have them demonstrate it, right? And show them how to do it, and then basically The Phelan test, what it would do is it reproduces numbness and burning in a person if they actually have a carpal tunnel syndrome. So that's one of the things we do, one of the assessments rather. And then of course there's the Tennel sign, direct percussion of the location of the median nerve at the wrist, produces no symptoms in the normal hand. And so they basically are tapping on the median nerve. All right. In carpal tunnel syndrome, percussion of the median nerve produces burning and tingling along its distribution, which is a positive Tennel sign. So these are just a couple of tests that we do to determine this. All right. And then take a look at the other information related to the wrists and the hands, how we inspect and palpate. And also your book talks about the different range of motion movements as well. So take a look at that as well. Get a general idea of what we're looking for. All right. All right. And the same thing applies to the hip. Make sure you take a look at that information as far as, so we're looking at the hip here. Look at the range of motion that we're looking at. So if we want to, this is a hip flexion here with the knee straight. So we're looking at a 90-degree, or this is what we actually want. This is extension, of course, of the other limb. So 90 degrees of the leg that you're flexing, 0 degrees for the leg that is an extension. This is a hip flexion with the knee flexed. It should be, we should see 120 degrees. I think they even have some tools that has these little degrees on it. Forget what they call it. It's kind of like I guess a protractor or something like that. And they can determine if the person, maybe they're able to eyeball it, but I would think initially you would have to, maybe have one of those types of tools to determine where a patient is as far as their range of motion is concerned. And of course, this gives you all the instructions here. No sense in me going all through that. It's too much information. And then, of course, we have the knee. All right. And so here's the knee here. All right. With this particular exam, well, just take a look at how we will instruct the patient. The person, as it says here, should remain supine with the legs extended. All right. Although some examiners prefer the knees to be flexed and dangling for inspection, so it just depends on your preference. The skin normally looks smooth with even coloring and no lesions, of course. And then, of course, you check out your abnormalities, what it can be. All right. And so just take a look at this information. Your book also talks about the ballottement test. And this is where you're trying to determine soft tissue swelling of the knee versus increased fluid, like an effusion in the joint. And let me show you what that would look like. So that's the bulge sign. So yeah, this is the ballottement of the patella here. Those of you who played any kind of sport where you can sustain a knee injury, this is something that may have been performed on you. So if fluid has collected, your tap on the patella moves it through the fluid, and you will hear a tap as the patella bumps up on the femoral condyles. All right, so that's how we would do that, the ballottement test. There's also a test that we do to assess for a meniscal tear. It's called the McMurray's test. Oh, here's the how we check the range of motion, of course, for the knee. Yeah, here's the Murray test here and how it is performed. And here you go. This particular image tells us how to actually carry that out, right? Perform this test when a person has reported a history of trauma followed by locking. If the knee locks, if it gives way, or local pain in the knee. Right, and just read the rest of that information, just get an idea of what that test will look like. So this is essentially why we would do um, this exam. All right. And then, of course, there's the ankle and the foot. Like I said, you all, this is quite a bit of information, and what I would prefer you do is I want you to take a look at your um, take a look at the focus sheet and make sure you focus on that information first and foremost, and then of course try to get in some of the rest of the readings with some of these other musculoskeletal issues. That way you're kind of prioritizing and you're not ignoring the rest because the rest can be tested in other situations. For example, CMS or your um, exit exam, and even NCLEX. So I do want you to go back and try to read as much as you can about what I don't mention on the focus sheet, if that makes sense. So anyway, take a look at the ankle and foot, same thing. All right, take a look at that. And see how we check for muscle strength, assess muscle strength by asking the person to maintain dorsiflexion and plantar flexion against your resistance. And so remember with dorsiflexion, you're you're pulling your toes back towards your head. And then I will have my hands on your toes, and I'm trying to prevent you from actually in the back. Or rather, all right. So say this is the I guess you could say the anterior portion of the toes, and so I will put my fingers here to create this resistance while you try to pull your toes back towards your head. That's dorsiflexion, and then of course I will place my hand in the ball of your foot, and I ask you to push against my hand while I apply resistance, and that would be your plantar flexion. And we're just looking or testing for strength um, with this patient, your patients. Let's see, wrist and hand. We're at ankle, feet. Hmm. So I did that one. Talking about. I guess this moved because it took my page all the way up. So ankle and feet. Yeah. So again, with here, um, 596. Here again, we're looking as far as range of motion for of ankle and feet. This is dorsiflexion. Remember, it goes back towards the head. And this is plantar flexion. It goes down. Look at the degrees here. We also do eversion as well as inversion, right? And of course, this tells us how to do that. This is what we're looking for. Looking for a limited range of motion or pain with motion. If that occurs, then we know that there's an issue, right? Assess muscle strength by asking the person to maintain dorsiflexion and plantar flexion against your resistance. And the abnormality would be they're just unable to do it, essentially. All right. And then there's the spine. Um, Now, with this assessment, I want you to take a look at how we would instruct the person. For example, the person should be standing, draped in a gown, open at the back, because that's what you're assessing, obviously. And place yourself far enough back so that you can see the entire back. You want to have a more objective view. And you're looking first, of course. You want to make sure that the spine is straight and that it doesn't have the curvature. We know that if there's a curvature, then pronounced curvature, then there may be lordosis. Um, or, of course, there's kyphosis, enhanced thoracic. That deals with the thoracic region. Lordosis is dealing with the lumbar region. The kyphosis, you usually see that with age, and the lordosis, you would see that with patients who are obese. All right. So take a look at that. And remember, I told you about um, if someone is injured, they're on workers' comp. We're trying to determine if they're ready to come back to work. And so this is what we're looking at. So check range of motion of the spine by asking the person to touch the toes. A lot of people um, probably can't do that. Look for flexion of about 75 to 90 degrees and smoothness and symmetry of movement. No, they're not bending or favoring one side versus another. So take a look at your book regarding that. And this is a little more specific. Stabilize the pelvis with your hands and check the range of motion. So you want this patient to bend to the sides, bend backwards, um, and also to twist the shoulders to one side then the other. This is more of a rotation of 30 degrees bilaterally. Or it may be 30 degrees going to the right and 15 going to the left because of some injury to certain parts of the spine. So take a look at all this information. You should be able to just read it, um, and hopefully it will stick better, right? Then there's a straight leg raising or the Lisiges, something like that test, whatever that is. It's basically the straight leg raise, more sophisticated term here. But your book talks about how to do that. Test positive if it reproduces sciatic pain. If lifting affected leg reproduces sciatic pain, it confirms the presence of basically a herniated disc. All right, and so just look at your book, how it asks or provides direction. Actually, I provided an image here. This is how that will look. And this is the spine, the part of the spine that is impacted. It's more the lower spinal region. Right. So take a look at that. We also like to measure the length of a leg, see if there's any discrepancies and whatnot. You will need a measuring tape. And so your book actually I provided an image for that one as well. Take a look at the image. And so we're measuring in centimeters, and it tells you where to place the tape measure. Now, they may not be necessarily equal, but as long as it's within 1 centimeter, then that would indicate that there's no true bone discrepancy. So, um, some people have shorter legs than the other, so it shouldn't be too pronounced. All right. And as far as the infant is concerned, we want to examine the infant when they're fully undressed and also on their back. And we also want to maintain a good ambient temperature in the room so that they're not shivering and cold and miserable and all that. And of course, just take a look at what we're assessing, the feet and also the legs. Any kind of positional deformities or a residual fetal positioning. You know, the fetal position, we don't want to see that. Looking at the forefoot to the hind foot, looking for tibial torsion as well as a twisting of or rather, it's a twisting of the tibia. There is a test as far as the hips when we're looking for congenital hip dislocation. This is something that you certainly want to be familiar with, the Ortolani's maneuver. This is a test that we perform. I think your book may show how that test is actually done. You'll see that again, certainly in pediatrics, so make sure you guys take a good look at that particular concept. Let's see, developmental. Yeah, let me show you guys here quickly what that would look like. It's called the Ortolani maneuver. You place the baby on the back. All right, that's how that looks. So you see how their hands are positioned around the hip area, and then they open them up like that. And I believe with this one, you might hear like a clicking sound. Or a clunk. Says the hip instability feels like a clunk as the head of the femur pops back into place. And of course, this would be a positive Ortolani sign. And of course, it does warrant a referral. Your book tells you how to do that. All right. There's also another test called the Alice test. It's also used to check for hip dislocation by comparing the leg lengths. All right, and let me show you what that looks like. Let me come out of that. This one is pretty simple as well. Take a look at how this is done. Place the baby's feet flat on the table and flex the knees up and scan the top of the knees. Normally they are at the same level. You see that? They should be at the same level. This one shouldn't be higher or lower, should be the same level. Finding one knee significantly lower than the other is a positive indication of a Alice sign and suggests a hip dislocation. And again, a referral would be warranted. Um, and of course, read through the rest of this information regarding assessing the spine, um, um, in particular, for example, say if you're looking at the spine, so you want to lift the infant and examine the back, right? And there's a way to do that. Your book actually shows that. You want to look to see if there's a normal single, kind of like a C curve. It looks like a C of the newborn's spine. By 2 months, the infant can lift the head while prone on a flat surface. And this builds that kind of concave cervical spinal curve. And it also indicates a normal forearm strength, that will allow them to do that, actually. We inspect the length of the spine for any tuft of hair, dimpling in the midline, any cyst or mass. And of course, normally there's none. Now, a tuft of hair over a dimple in the midline could indicate spinal bifida. All right. Now, a small dimple in the midline, anywhere from the head to the coccyx, can suggest a dermoid sinus. So, and the mass, of course, can indicate the meningeal seal. So, let me show you how they're holding the baby. You see that? See how they are holding the child? Uh-oh. Yeah. So that's how, and they're just assessing the back for these abnormalities. This is a way to test the baby's strength, right? Test muscle strength by lifting the infant with your hands under the axillae. A baby with normal muscle strength wedges securely between your hands. See, those arms will be kind of down and wedging your hands. A baby who starts to slip between your hands shows weakness of the shoulder muscle. So this is just how we test for muscle strength of the shoulder. All right. Like I told you guys, this one can be pretty long, and so I try to progress through it a little quicker, and so because it will just require reading, your reading of this information, right? And then go ahead and look at the assessment information for your preschoolers and school age children. Take a look at that. What is that doing there? Also, take a look at your adolescents. Remember, with your adolescents, one of the main issues here is either kyphosis and more importantly, scoliosis. All right. So take a look at how we would perform that. Remember, we used to do that a lot in school. They would check to see if we have scoliosis. Kind of a nice health promotion program. And then take a look at the pregnant woman. Expected postural changes in pregnancy include there's progressive lordosis, and then of course towards the third semester there's this anterior cervical flexion, so the neck is more flexed. You'll see kyphosis and slumped shoulders. When pregnancy is of course at term, the protuberant abdomen or stomach and the abdomen is protuberant, and then there's this relaxed mobility in the joints created by this waddling gait. They look like a duck as they walk. I'm sure our pregnant students, you're quite familiar with this. And then there's the aging adult. Just take a look at this piece of information. Right. Postural changes include decreases in height. We talked about that. It's more apparent in the eighth and ninth decade. They just get shorter, right? Kyphosis is common with the backward head tilt to compensate. That's what they're doing. Bony prominences become more marked because you're losing a lot of your subcutaneous tissue. There's a range of motion testing, that get up and go type of testing, and definitely performing the functional assessment, really important. Because as we know, they have a lot of deficits, self-care deficits, and what have you. Take a look at the health promotion, patient teaching. These are the areas of focus. Diet, in order to protect and maintain healthy bones, so they have to make sure they're drinking adequate milk. There's smoking cessation. Hopefully, they're not smoking by that age, right? Alcohol consumption, exercise promotion makes strong, healthy bones. Osteoporosis screening, especially in white women, and also fall prevention. And so they have to even go out to their homes, a home care nurse to do a home safety assessment. They may have like throw rugs on the floor, may have wet areas. I mean, whatever it is, you do your assessment and determine what, put a plan in place, things that you can do to protect this patient. This is where I'm going to kind of speed up because the remaining slides speaks to a variety of musculoskeletal issues, and there's some you guys would be that I will expect for you to know. Probably rheumatoid arthritis and osteoarthritis, as well as osteoporosis, are the main ones here. So just look at your focus sheet, and that will tell you which ones to place more focus on. All right. And then, of course, as far as, of course, that was of the general general effects, general issues affecting the joints, right? Of those general joints. But this one is more specific. It speaks to your shoulders, elbows, and also spine. Take a look at these different issues here. I can't say right offhand which ones that I want you to focus on, but just wait for the focus sheet and then you'll see what that's about. And then there's the wrist and the hand, more than likely carpal tunnel. And then, of course, take a look at the conditions caused by chronic rheumatoid arthritis. And so I'll tell you which one of those to really focus on. Then there's the knee and ankle, foot issues. And so take a look at these different issues here, the ankle and the foot. All right. Yeah, as you can see, this is quite a bit. It's quite a bit. We can't expect for you all to know all of this. So we'll let you guys know what we do expect for you to know. And then, of course, you have these congenital or pediatric abnormalities. The one that sticks out is the club. Well, actually, the dysplasia of the hip, club foot, spina bifida. Those are some of the main ones to think about. And then, of course, the summary checklist of musculoskeletal examination, how we generally proceed with testing. We inspect first, we palpate. Of course, we're looking for tenderness and pain and what have you. Then, of course, the range of motion. We talked about the various joints and their normal range of motion. Of course, we expect different or limitations in the elderly. Check it out. So measure with the goniometer. I think that's what I was talking about here. Let me see. I call it kind of like a protractor when you're trying to assess joints. I thought there was something that they used to evaluate or determine what that degree is. So here it is here. It kind of reminds me of a protractor. Maybe it's a protractor of sorts, but that's what it looks like there. You got these degrees of what that joint should be doing, right? A goniometer, right? And then of course muscle testing. We have a grade, a scale to look at for that as well. And that's about it. So this is like an hour and 40 minutes, which could have been a whole lot longer, but because I'm not going over all those other particulars, issues related to the different joints, it makes it a little shorter. So anyway, so I'm going to end it here. I'll go ahead and get this out to you all. Again, just make sure you do your readings. But specifically, make sure you focus on your the focus sheet, which I'll get that out to you guys shortly. Thanks a lot, guys. Stop presenting.